Diabetes Food Service has been described as a Cinderella service for probably at least the 30 years I've been involved in, and you think, why is that and why is it remaining? However, it's not going to be all gloom and doom. I think many of the statistics you'll be well aware of, I'm sure. You're well aware of the global pandemic that diabetes actually is, that more than 300 million people living with diabetes, and by 2030 will be about 500 million. And these are relatively conservative estimates if the trends continue as they are. We know some of the reasons that contribute towards that. We're aware of the increasing sedentary nature, the increasing obesity are certainly major risk factors for development primarily of type 2 diabetes. And depending on which way you want to look at statistics, but we know that every 8 seconds someone in the world dies from diabetes, and it's one of them among the top 10 causes of disability, including those who undergo amputation, stroke, and so on. If we come a little bit closer to home in the UK, we're looking at 2.9 million in the UK with diabetes currently, and if the trend continues, rising up to 5 million. And I think, to put into context, when you get this with the backdrop, as we know, of those austere times, and we know in real terms the nature of NHS budgets, we know that we're going to be creaking a little bit, aren't we? We know that the figure is 4 times higher than the prevalence of all cancers. And that in terms of spending, and this is quite an interesting fact, that NHS spends in diabetes almost 10 billion or 1 million per hour. 80% of NHS spending in diabetes goes into managing potentially preventable complications. And I'm just going to share with you some of the data today, really, to make you think about, wonder why we're not winning. Why, when we've got some quite good evidence of what we could be doing and should be doing in preventing the complications, why it's just maybe not quite working out so well. Half of all deaths from diabetes result from cardiovascular disease, as you know, including heart attack and stroke and so on. So the problem, worldwide, if you extrapolate data from statistics, they're quite good strap lines to give to ministers when you go into lobbying and so on, that every 30 seconds somewhere in the world lose a limb due to diabetes. In England, 61,000 people with diabetes already have or have had a foot ulcer at some time. 100 people a week lose a toe, foot or lower limb to diabetes, and that's in England. These are the facts of the matter. The cost, various costing models, and there's a very excellent paper from Marion Kerr looking at health economics, and there's another excellent paper on estimates of costs, including indirect costs, a paper in diabetes medicine from Hex et al., but it shows that the cost to NHS on foot ulcers and amputation is between 639 million to 662 million. So, you know, when you begin to dip into what money is spent in diabetes, I used to think in my naivety many years ago that there weren't enough resources given to the Diabetic Food Service, and that was why it was a Cinderella service. But if you look at the converse of that, really, in this one sense, there's a tremendous amount of money spent in diabetes, but maybe it's not always in the best way, if the evidence suggests that up to 80% of amputations are preventable. Amputations of foot ulcer associated with poor quality of life, and I'll show a little bit more data about that in a minute. In terms of patients, we heard, I remember Professor Keith Harding said earlier on about a holistic approach, and many of the patients have looked to ask them if they've got diabetes and other comorbidities. People with diabetes who present with foot ulcers are actually quite ill people. By the time they have a foot ulcer, it's quite a window to their overall general health. And if you look at the data, only 2/3 of ulcers eventually heal without some form of surgery. 28% result in amputation. The survival rate post-amputation, 50% after 2 years, and the survival rate, which is quite worrying with those with ulcers, is only 56% after 5 years. So arguably by the time they've developed a foot ulcer, their future's not looking too clever. It's probably a window, and it probably reflects the amount of concomitant vascular disease. There may be chronic kidney disease and other comorbidities that suggest the prognosis is relatively poor. And then the quality of life with those that do have a foot ulcer, there are quite interesting studies from 2 Swedish studies looked at the quality of life indicators and found that those diabetic patients with a foot ulcer had a lower quality of life than those for osteoarthritis, COPD, and even patients undergoing dialysis. And I would just ask you to factor that in when it comes to the easy way in which we often accuse as clinicians sometimes about patients' lack of interest in their health or lack of concordance. And when you factor in that up to 40% of all people with diabetes suffer from some form of depression at some stage, and look at their quality of life when they do present with an ulcer, you get the picture that it's going to be a long, hard slog, isn't it, in terms of their possible motivations, if you will, for certain intervention behaviours. Again, looking from a piece of work that Robbins carried out in 2008, just looking at the 5-year mortality, again, interesting strap lines that those with foot ulcers have a reduced mortality, even more so than, say, breast cancer, prostate cancer, and Hodgkin's disease. So these are important facts, I think, to get the headlines. And for those who get involved and engage with the media, as we've been doing more recently with our Putting Feet First campaign, to highlight the awareness of diabetic foot disease, these are sort of the headlines that the media like to get hold of. Bringing it down to a more personal fact about people undergoing amputations. This is from a well-known American actor in a television comedy, Seinfeld. He called emergency services from his apartment in Cincinnati and said, "I shot myself in the head but didn't work, I need help. I was supposed to go to the hospital, I didn't want to. They were supposed to amputate at least a few toes. I already had one leg amputated. I'm tired." And his leg was amputated due to diabetes. Now, I don't want to portray amputation as if it's something so nihilistic approach. And we have to remember that amputation is a very, very good therapeutic intervention and will often helps to save people's lives. So I want to sort of alter the balance, if you like. But I think in situations like this, where maybe even the amputation might have been preventable, it's quite sad and quite poignant, isn't it? In the UK, I've already said about 6,000 people with diabetes undergoing leg, foot or toe amputation each year in England. Half will die within 5 years, and up to 80% are preventable. Now, you would think that these figures would have an impact, wouldn't you? And you think, well, let's get this prevention. I have to tell you, it's not rocket science to get the prevention programme. It's not a mystery about how do we prevent these amputations. And that's maybe the galling aspect about diabetic foot care. Again, from the BBC, from Northern Ireland News, call to end diabetes amputations. And they talked about the Putting Feet First campaign, more about that in a minute or two. But a single preventable amputation is one too many. So the fact that hundreds of people in Northern Ireland have endured unnecessary foot amputations is nothing short of shameful. There's a really interesting paper, you may have come across it, from Naomi Holman et al., looking at the variation in amputation rates in the UK. And obviously one has to be very careful at interpreting data, but when they factored in factors like social deprivation, smoking and so on, they found that the reasons for the variation in healthcare, and I have to say the variations in amputation rate across the 151 primary care trusts in England varied up to tenfold. And their conclusions in that paper were there were two major factors. One was delayed referral, another one was clinical decision making. And I'll leave that for food for thought. I think one of the significant factors from the National Clinical Audit Office on diabetes services for adults stated that £34 million could be saved in NHS if there was a 50% improvement in the delayed referral. So it makes you think, is it the system? Is it the training and education of lack of recognition? Is it patient behaviours? A bit of everything. And you've really got to dig deep to find out why we're still getting this pretty gloomy picture. Getting it right, I think this, I put this up with 100 years of diabetic foot care. I realised that this year, sadly, I turned 60, which I don't know if it's sad or not, but getting on, and I think when you get on, you begin to ask to write various papers, and I was asked to write this paper on 100 years of diabetes foot care. I did state the fact that I wasn't around 100 years ago. But it does strike me that it's quite interesting when you dig deep into the UK data that as far as recorded evidence of the multidisciplinary team, we heard from Professor Harding earlier on about the multidisciplinary team approach, that Mike was telling me not so terribly long ago, Mike Edmonds here, getting his award at the international meeting in the Netherlands last year for his outstanding contributions to the diabetic foot. And he was saying, I asked him, how did it all start at King's with the clinic you run? He said, well, it was the chiropodist, as we were known then, who was seeing so many diabetic patients at King's College Hospital, and she kept calling Mike Edmonds into the clinic to have a look at the foot of the patient and to give an opinion. And she said, wouldn't it be easy if you just saw the patients together? There's so many of them. And that was the germ of the idea, that there was the notion behind the multidisciplinary team approach to care. And he presented his findings back in 1986. And even then, from his evidence of the ulcer patients, he managed to achieve a reduction of amputation rate by 50%. So you think, well, that's a wee while ago in 1986. Surely it must be now common practice. Let's have a little look at the data to see if it actually is or not. From Karl Backer, the sort of godfather of the diabetic foot, instigated by the International Diabetic Foot Group, said that it is possible to reduce amputation rates if you have a care strategy, appropriate prevention, the MD team approach, appropriate organisation, close monitoring, and education of patients and health practitioners. It's easy, it trips off the tongue, doesn't it? But when you actually go round the trust to look at organisation and try to find out what's going on, I don't know how many of you have spent time to find out what goes on in your area. It's quite confusing, and it's quite opaque to get to the truth of the matter of what actually happens. And our foot care pathways just guidelines that sit in shelves, or they actually adhered to. So, I could have put up about 40 slides that really send you to sleep, more so than you're feeling already, with all the guideline documents. We have a plethora of evidence-based documents. We have we have probably in diabetes more than any other chronic condition. We've got the evidence and we've got the data. If any of you have waded through Clinical Guideline 119, fantastic document about every single aspect of care with evidence-based medicine supporting it all the way through. We know from the National Diabetes Information Service and the National Diabetes Audit, we know what to do. So the next question really I put to you, is it being done? And we'll have a little look at some of the what's actually taking place. But I would say to you, there's absolutely no excuse not to know what should be done. It's not a lack of knowledge. Whatever else it is not a lack of knowledge. Getting it right, the quality standards, and they were just this year were changed to, for sake of straightforwardness, if you like, that people with diabetes at risk of foot ulceration receive regular review by a foot protection team in accordance with NICE guidance. That's a NICE guidance quality standard that probably adhered to in the new world of NHS and the commissioning guidelines. I've been around quite a few trusts, and I ask them, I'll say, what's your foot protection team like? And they say, what do you mean? What's a foot protection team? Never heard of it. I said, so you don't have one according to NICE guidelines? No, who's that? I don't know if it's a figment of my imagination, if it's me, and I don't know how many of you are in this. Can I just say a show of hands, how many of you know of a foot protection team in your area? So, it's bewildering, isn't it? I find it all bewildering. People with diabetes with a foot problem requiring urgent medical attention are referred to and treated by a multidisciplinary foot care team within 24 hours. This caused a great stushy at the launch of the NHS Diabetes Foot Care Networks, because there's very few centres can actually achieve this, and we're a wee bit worried about this will be against us in the increasing litigious society we live in, that they refer to NICE, this is a quality standard of NICE, this is what's going to be commissioned. Do you think many trusts in place and hospitals can actually provide this care within 24 hours? What do you think? Probably not, and that's the situation. Apart from one or two notable exceptions, I won't name them. So we know from the NICE guidelines, suggest that each hospital should have a care pathway. The team should consist of healthcare professionals with specialist skills, and the multidisciplinary foot care team should normally include a diabetologist, surgeon, diabetes nurse specialist, podiatrist, tissue viability nurse, and the team should have access to other specialist services required. Well, that makes sense. There's loads of evidence to show that multidisciplinary team correlates with really good outcomes. So when it comes to the national inpatient data, and some very interesting data to look across the 151 trusts in England, let's have a look and see what's actually happening. In the data from 212 hospitals and 136 trusts in England, we found from the inpatient data 40.5% did not have a multidisciplinary foot care team. So when it comes to going, I don't know how many of you actually know who your local commissioners are going to be, the CCGs and the Health and Wellbeing Boards and the Clinical Senates and the Brave New World. How do you commission a foot pathway on a team if they don't actually exist? How does that happen? How does that work? And for those who get involved, I think something happens when you get older. You get more involved in the politics, I think, somehow, and want to know why on earth what's happening. But that's the reality now. So it's a bit disappointing, I think you'd agree. Of those with active foot disease, last year, 61.9% had an input from a member of the multidisciplinary foot care team within 24 hours. Now that's those who have active foot disease within hospital. So what's going wrong? Why isn't a member of the team contacted right away? It's supposed to be. It's an improvement on the previous year's data, I'll give you that. But it's not too good. It's not too good. If we look at those with active foot disease who were seen within the last 7 days, then it increased up to 71.7%. But you wonder about the other nearly 30% who are still waiting to be seen. Have you ever looked at the number of people with pressure heel ulcers who have got diabetes in hospital care? I won't share with you that data today, but it's really quite alarming. People with diabetes, really, it wouldn't take too much time and effort to have a look at their feet. If they come in and they're at risk and they have neuropathy, for goodness sake, why are their feet not at least checked and looked at? Now, the excuse I always hear from most places is they're too busy, and I'll say, well, therefore it's not a priority. But there we are. There may be other reasons for it. Foot assessment on admissions of patients, of documentation within the notes of foot examination within 24 hours, 22.2%. In hospital notes, that's in the audit. Examination after 24 hours, only 4.5%. A foot examination at any time, 26.7%. So it's so easy to forget when they come into hospital, isn't it, that to even check and look. So the data's there. The data's there. Getting it right in the community. I already mentioned the fact that foot protection teams don't seem to exist anywhere, and yet they're recommended from NICE. It does suggest it should be community-based. We had an argument up at the launch of the NHS foot care networks, because in the Putting Feet First document, we're very careful not to actually name the healthcare professionals who make up the foot protection team. Personally, I don't care if it's a nurse, tissue viability nurse, podiatrist, whoever, as long as the team's actually there to carry out that preventive role. It's just not coordinated. It's not clear. So there's no standards across the country. It's early days yet to get involved. I don't know if many have had talks with commissioners in their training about commissioning a service. We need evidence. Is there evidence there to support the team? No. 30% of patients receive no foot screening in the community. 50% unaware of the risk score. Now, you'll be aware of the outcomes and a framework that it's a voluntary service that GPs can engage in, and they're financially awarded to reach certain targets. And we're finding that many of the patients, up to 50% of the audit, were unaware of the risk score. Now, it's interesting that on the QOF points, to be eligible for the QOF incentive, GPs and their practices have to record their risk status, which is great. It's an improvement on previous years. But they don't have to do anything with the patients thereafter. There's no incentive to refer them on for education or incentive to refer them on to any service. And with the result, when we interrogate the data, you'll find there's no correlation between screening and improvement in reduction of amputation rate. And the interpretation of that is that screening doesn't make any difference in prevention. And, well, that would be right, because if they're just getting screened and nothing happens... Now, I'll put it to another way. If you were diagnosed as having... if you were assessed as being at high risk of breast cancer, that would be quite alarming, wouldn't it? You think you'd get a backup service thereafter, education, further referral. But if you put at high risk of a foot disease, which carries greater mortality, there's no incentive to do anything with those patients. And many of the patients who get allocated a risk score, get told they're high risk, I don't know how they feel about that, don't get referred on necessarily whatsoever. Is it me or is it Potty? No preventative education programme required, and we are behind the scenes trying to influence the QOF arrangements so that there's some added incentive to get the referral onwards, although many services say they haven't got the capacity if they do refer patients onwards. But there we are. So why are we not getting it right? Cinderella service for decades. Feet aren't glamorous. And you need champions, and every single trust needs a diabetologist or a surgeon or someone else who is a champion for diabetic foot disease, because without them the service doesn't work and doesn't exist. And of course, people deserve more than that, don't they? It shouldn't be left in the vagaries of interest of clinicians whether or not they run a foot clinic or not. They should be available to everybody. And I think the variation in healthcare, as you're well aware, is one of the domains within the National Outcomes Framework. So if you learn the language to go to commissioners that fits in with the National Outcomes Framework and domains, you've got to really put forward your case very cleverly to fit the outcomes that's the driver of some of the policy within the Department of Health. The other reasons for it, the healthcare systems are not clear enough about referrals, differences in clinical decision making, interfering politicians. I had the pleasure of having half an hour with Paul Burstow, Secretary of State for Long-Term Conditions at Richmond House, and we're making some progress, and he was really very keen in diabetes and moving things on, and we're all very pleased with the outcomes, because we're probably a bit deluded. And then the next thing, in the reshuffle, he goes and gets sacked. So, you make some progress, but it's 2 steps forward, 1 step back. Absence of professionals interested in feet. Sadly, this is still a problem. You really do need these champions, and it's crazy not to be. When you look at the associated burden of mortality and costs, there's every reason to get interested in feet. The Putting Feet First series of documents, you may well have read them, been part of them. They very clearly set out quite easily commissioning specialist services and then the skill set and framework to go alongside. Guidelines, frameworks galore, we all get involved in them and we review them and participate and we think that's great. But making it happen, that's the difficulty. I was involved in reviewing some work from the King's Fund where they were developing work to inform commissioners for best practice in commissioning. And the diabetic foot came up as one of the tracks they were working on. And they came up with a 26-page document for diabetic foot service. And I didn't want to, dampen their enthusiasm for the work. But I said, do you really think commissioning groups are going to look at a 26-page document on diabetic foot service? So a colleague, Professor William Jeffcoat, who you may well know, and together with other colleagues in Diabetes UK and colleagues from the Society of Chiropodists and Podiatrists got together to put a one side of A4 of a final document pulling it all together for commissioning processes. This was the kind of launch pad of our Putting Feet First campaign. And it's quite straightforward about utilising all the NICE guidelines, all the previous documents in Putting Feet First, including the sign guidelines, clinical guidelines, so on, prevention of disease, treatment of active disease, and management of the person whose foot disease has been treated. The only thing extra we added was reduction of cardiovascular risk. Work from Matthew Young in Edinburgh Royal Infirmary demonstrated that many foot ulcer patients have coexisting cardiovascular disease. And those foot patients, if in the foot clinic you think not just feet but think heart, and participate in a more aggressive cardiovascular risk reduction for those patients, it made quite a significant difference in Edinburgh data of increased mortality rates as well. So we also thought that from a political point of view within the Department of Health and Ministers, that if we mention about the cardiovascular disease as well, it ticks another box with the ministers of saying, yeah, that sounds like a good idea. Alongside the Putting Feet First, we also talked to our Scottish colleagues, and many of you may well be aware of the simple traffic light system, just showing you the risk status and what programme of care and action should be taking place. And we sent out a copy of the Putting Feet First to every single CEO in all the trusts across England. Now, whether it makes a blind bit of difference or not, we don't know, but at least we're trying with the campaign to raise awareness. So, just on the Putting Feet First campaign, we want to work with partners to reduce amputations. They're all obviously aspirational and nothing you wouldn't, I'm sure, agree to put an end to the wide geographic variations in standards of foot care for people with diabetes, raise awareness of the seriousness of diabetes and so on, and our objectives to improve the quality of foot checks and appropriate referral by competent practitioners, to increase the proportion of localities delivering the foot care pathway. In other words, we thought that through the Putting Feet First campaign and using Diabetes Voices and getting hold of the media to support it, we're really launching quite an aggressive campaign now. I don't know if you've been aware of it across both in BBC radio and television, left, right and centre, and across all the newspapers. Finding that diabetes voices makes a big difference, and the politicians get a bit twitchy if their constituents are having a go about the nature of the services. In fact, I have to tell you, one of the Andrew Lansley's office phoned me up last summer, and in a great panic, one of the civil servants there wanted to find out what the minimum standards for diabetic foot care were, because it was falling short, and it was in Andrew Lansley's constituency, and she was and a whole lot of information that she could easily have got access from the internet. And it's amazing civil servants that get hold of you at all sorts of times of the day, and you think, I won't even start. It just seems to me madness the way they go about getting information. But we're doing our best. I think we're having we launched a meeting at the Putting Feet First campaign in Glasgow at the Diabetes UK meeting, and we're getting a bit more aggressive now. We're in for naming and shaming, and a lot of the local trusts don't like it, but actually now there's quite a strong correlation between those who don't have a multidisciplinary team and amputation rates. I think we're having to get a bit more aggressive in some ways. Whether it will work or not, who can say, but at least we're raising awareness. And really, the power is going to be with patients. We're looking at arming them with their own cards to take to healthcare professionals to make sure that they're entitled to an annual foot check. Make sure you take your shoes and socks off. I know it sounds so ridiculous, but many annual reviews, you wonder if they even do that. Information education about individual foot check results, the risk score, a contact number of the specialist foot care team to call. If your feet are assessed at high risk, ask to be referred to foot protection or MD team. And if you go into hospital, ask to see the diabetes team and have your feet checked. And the diabetes patients have agreed that they're going to be armed with this, and maybe that it's really those little initiatives that might make a difference to try and improve the situation. And these are just some of our key asks within the services. We really are now just going out there as champions within the NHS Foot Care Network, champions via the setup. We're going and knocking the door and hoping that the Commissioner's taken up, but we've got to have good evidence to support some of the savings we can make. It's all about cost at the end of the day. This is about working together by Putting Feet First campaign to improve things. And I just want to mention the fact of what we're doing, continuing lobbying, we're working with the foot care networks, the Diabetes UK campaign, examples of good practice, and engaging with CCGs and health and wellbeing boards and so on to try to get the message there. Just very briefly, 2 examples, and I'll shut up, of good practice in Southampton. This is evidence from the Marion Kerr's work. They found that the estimates of the impact of improved care by appointing 3 podiatrists, 2 diabetes specialist nurses, 0.2 of a dietitian, annual cost 179,000, reduction in length of stay days, and reduction in annual major amputations, annual savings. It can be done. Savings, and Paul Burstow was quite interested in hearing the savings. Sadly, at Southampton, that funding disappeared and their amputation rates subsequently increased, but that's another story. In Middlesbrough, James Cook Hospital, multidisciplinary team, weekly 4-hour consultant-led clinic with a district specialist nurse and 2 podiatrists, care pathways and protocols established, educational events organised. There's the staffing cost, 33,000, annual savings, 249,000. So not only do you improve care, but you save money. You think that's quite a good argument, wouldn't you? You think it's a fail-safe, but it's still a struggle to make that argument, I have to tell you. Penultimate slides. It's a changing landscape out there. You heard this morning on the radio about the efficiency savings that have to be met, and many financial managers in NHS are saying that it's going to be pretty tough and affect quality of care to patients. We know that diabetic foot disease is incredibly costly, and we know that the trend's continuing, and yet we're having a decreased budget and an increasing problem. It doesn't take much to work out the type of problems are going to be in. So I'll leave you with my take-home message. The final thought is, for 1 mistake made for not knowing, 10 mistakes are made for not looking. I think it's a good medical axiom there that, look at your patient's feet, look at the service, look what's going on, and become a champion for diabetic foot disease. We need all of you to champion that particular problem. There's so many problems out there with ulcer care, but these guys, they have the greatest challenge to their mortality. Thank you very much.
Thank you, Alistair.